for today, which is looking at the numbers that we have here. I think I'll start with our exam preparation. I'll start with exam preparation because this is really important, so that I give feedback to you people who've been doing your exam. So for people who haven't been able to join, I'll post the lecture there. So I've put all the people that are supposed to be in this meeting. And the first thing I'm going to say is that I'll make first the general comments on what I've seen in the way you are answering the questions. So firstly, I see that your basic anatomy is not good. So you don't know the anatomy of the uterus, for instance. You know the uterus has a cervix, it has a body, it has fallopian tubes. What are the parts of the fallopian tubes? What is the anatomy of the cervix? And so on, the basics, the anatomy of the perineal muscles, the pelvic floor. Those are things that we are dealing with in obs and gyn. Anterior abdominal wall. In the last UNILAS exam, I asked about what layers do you cut through when you are doing a cesarean section. Some people can't even mention that they cut through the skin. They cut through the rectus sheath. They cut through the peritoneum before they access the uterus. That is really basic anatomy, and we should know all that stuff. Partograph, I can't say much about the partograph. All I can say is that we have a partograph tutorial that we've done, and it's there posted. Please, please, please look at the partograph. There's no reason. I know the performance for both Levy and UNILAS. I haven't marked the Apex ones that just did right now, but I've seen that the performance has really improved with regards to partograph. So just go to that tutorial, look through the partograph. If you have any problems, you can ask, we can help you. So there's no reason to fail to plot a partograph. Then magnesium sulfate. Magnesium sulfate dosing, you need to know the loading dose, maintenance dose, but I see that most of you are still writing dosages in milligrams. It means you've lost all your marks. Magnesium sulfate is dosed in grams. So make sure you have that sorted out. Magnesium sulfate is dosed in grams. Make sure you are writing the correct dosing. Family planning, there's no excuse not to know family planning. Depo-Provera, noethistyrone, all those family planning. Just look at your 10 teachers chapter on family planning. Then I've seen infection prevention again is a problem. The basics, you people don't know where to throw your sharps. You don't know where to throw your gloves when you do your procedure. Does it go in the bin with a black liner? Does it go in a bin with a yellow liner? People are still struggling with that. The MVA, manual vacuum aspirator kits, its parts, disassembling it, putting it together, charging it, knowing all the parts. That tutorial has been done. Just look at it. If you have any problems, you ask. If you have any, you want to have some physical contact with that instrument, I have that instrument. You can ask for it. So that's all I can say about the MVA. Then again, you are still having problems summarizing. I gave a history to the previous UNILAS team. Gave them a history of a patient and said, can you summarize the history? People can't summarize the history. So that is, again, something you really need to practice. If you are given a full history, how do you summarize? You have to say parity, gravidity, age of the patient, the reason they are there, and then you can add other significant findings in the history, but you can't forget name, age, parity, gravidity, the reason the patient is there, and then any other positive findings and any other significant negative findings. So that is about summarizing. Then we've already talked about C-sections. You need to know types of C-section. What is an absolute indication? What's a relative indication? Again, there's no need to struggle with these things. The tutorials are already there. Just go to that YouTube channel, go to the university where there's free internet, download or whatever you are doing, just have the tutorials. Have made those tutorials specifically for you to have an easy time during your exams. Because like I say all the time, we can't hide what we want you to know. So that's why those tutorials are there. The exam is there for you to know things that are important. We are sending a message during an exam that these things are important, you have to know them. So just be aware of those tutorials and look at them. Then lastly, neonatal resuscitation, just look it up. Then your logbook. Your logbook has a template on how to do an obstetric examination and how to do a history. Those things should be known by heart. So I can't say more about that. History, sequence should be known by heart. Examination sequence should be known by heart. There's no way around that, because you find that station where it says, do an obstetric exam or take a history from the patient with an examiner on the side watching. So there's no reason that you should struggle with that. Okay, so we go to the slides. So these are the stations that will always be there in one form or the other. So this, we call this, this is like a blueprint. So these are the stations. There's no really other stations that you are going to see apart from these stations that you have in front of you here. So there are about 15. But when we do your exam, we usually do somewhere between 10 and 12 stations. And these are the particular stations that will be there. So I have an OSCE example that will go through to see how the exam was set, and then you can go through. But you can see from this blueprint that you need to know your history. You need to know how to examine a patient. You need to know infection prevention. And the tutorial is there also on that YouTube thing. You need to know the common investigations that we do in OBS and GYN. Beta HCG. Hello.
Sorry, Dr. Shan.
Yes.
We can't see the blueprint. Are you projecting it on this?
Yes, the blueprint is just in front of you.
Oh no, we cannot see it. It's still stuck on the destructive obstetric procedures. The
Oh,
slide.
really?
Yes.
Someone should have said, sorry. Can we see it now?
Yes.
Oh, sorry about that. I thought we are all on the same page. Okay, so that's the blueprint there. So history, examination, infection prevention, the common investigations, the special investigations. The special investigations would be something like a beta HCG, something like, you know, your hysterosalpingogram, things like that. Those special investigations. Of course, a full blood count is common and so on. Your surgical instruments, again, we have a tutorial already on the surgical instruments, and I made sure that I put all the surgical instruments there so that you don't have any surprises. So that's about surgical instruments. Then we have sometimes a procedure station, if we have enough examiners, where you do like do an MVA or do a vaginal exam or do hand washing or do gloving, things like that. You do a certain kind of procedure. Then we have Partograph plotting and interpretation, which we've already talked about. On neonatology, we usually ask you for ABGA score. We put the parameters there, you calculate the ABGA score. And the other thing about neonatology is that fetal skull. That fetal skull is important, the anatomy of the fetal skull. Then the other thing about neonatology is the common, what do you call them? The common abnormalities, spina bifida, you know, your gastroschisis, and all those common neonatal abnormalities. Then you need to know your IV fluids, your dextrose. Where do you use dextrose in obs and gyne? Where do you use normal saline? Where do you use Ringer's lactate? Even your cannulas. A green cannula, how much fluid does it deliver in a minute at its maximum? A gray cannula. Your specimen bottles. What do you use the purple bottle for? What do you use the blue top bottle for? What do you use the orange top bottle for, and so on? I think I showed you all these funny things. We have a tutorial about them, so check them out. These specimen bottles. What is this one used for? What is this one used for? The blue one, things like that. These blood sugar bottles, these full blood count bottles, these bottles we use for coagulation procedures and investigations. So all these things are important. Then I've talked about specimen bottles already, communicating with the patient, counseling, common surgical procedures, scissors. We already talked about anatomy and physiology. Yeah, so this is an obstetric exam, for instance. So it's saying list the steps in performing an obstetric palpation as outlined in your logbook. So I already talked about this. There's another team which was asked about what is this nurse doing wrong here? So if you've been examining the patients, you know that when you are listening to the fetal heart, you shouldn't hold on to the fetoscope. Some people mentioned that why is her hand on her abdomen? Some people mentioned the amount of exposure here. You are supposed to expose from the symphysis pubis to the xiphisternum. Is the patient exposed like that? The patient should be in anatomical position. The nurse should be comparing the pulse of the patient and what she's listening to. So all those were the possible answers. And of course, people were lost. I don't know why they were lost. We've talked about this already. This is Partograph. Just refer to the tutorial that we've already had, how to plot. My only advice on Partographs is that you don't have enough time. 6 minutes is not enough for you to plot the Partograph if you do it wrongly. So the strategy is that when you start reading, you start plotting. Don't wait until you read everything to start plotting. So if you hear that the patient is Sandra, just write Sandra. She's 24-year-old, write 24-year-old. She's gravida 3, write gravida 3 on the Partograph. If she's 39 weeks, write it. If you see the time she came, just write it. Don't wait to read everything for you to start plotting. That's the thing I see students making a mistake on. Don't read everything and then start plotting, because the way your Partograph questions are done these days is that we separate the plotting and the interpretation so that you have enough time to plot. So we are not going to ask you to interpret, generally speaking. If we want you to interpret, we will do 2 Partographs, one for interpreting and one for plotting. That's what we are going to do. So just make sure that you concentrate on plotting as you go. Don't wait until the end. So that's my only advice there, because that's the mistake I've seen. So then the students don't finish in time. So this is an example of a Partograph where you are asked to interpret, and I'm sure we all know how to do this. There's no reason to go through it. So we've seen that for this particular patient, the problem there is that there's no descent. The patient was on the same descent the whole time. And then we've seen that the labor progressed and then stopped. So there was secondary arrest of dilatation. So that's an abnormality there. We've seen that the fetal heart is below 100. We can see that there was blood in the liqua. We can see that there was meconium in the liqua. So this is really a fetal distress. and so on. So that's about interpretation. I don't know what's happening to this thing. Anyway, so we've already talked about APGAR score. I can't say much there, just memorize. When you're delivering the babies, memorize how to do an APGAR score. Then we've already talked about contraception. There's no excuse for not knowing contraception. IUCDs, your combined oral contraceptive pill. There's this thing here where my cursor is going. This is Implanon. I saw that people don't know Implanon. When they put on a woman 2 rods, usually that is Jadel. But in this case, we have Implanon because Implanon has only 1 rod. Then this one here in purple is Depo-Provera. People don't know how often Depo-Provera is given, which is unfortunate. Then this is a Mirena down here, which looks like an IUCD, but it has levonorgestrel coated in it. So normally the question on this one is what hormone is released by this thing? How much hormones does it release every day? And there's a question there on non-contraceptive indications. We know that a Mirena is used for menopausal women, and it is used for menorrhagia. When somebody has heavy menstrual periods, we use it to reduce the bleeding. So this is just really about your reading. Then we have all these just examples of drugs. Just know your common drugs. So you look about indications for those common drugs. You talk about contraindications. You talk about mechanism of action. We talk about route of administration, all these things. So I've just given examples of the common drugs. You can see we have methotrexate there, mefenamic acid. Mefenamic acid, we have mifepristone. We have clomiphene citrate, that infertility drug, which used to induce ovulation. We have tranexamic acid, commonly used for PPH in our labor wards. We have magnesium, the famous magnesium sulfate. We have anti-D, and we have
Dr. Sharon, there's some
yes.
students asking to be let in.
It's full.
Okay.
Yeah, the application I have only allows in 100 students. So you can pay you people so that you can allow in more people.
Okay.
Yeah, so we have magnesium sulfate, we have anti-D, we have oxytocin, we have noristerat there in the corner at the bottom, the brown one, the one I'm showing there. That contraceptive that we give every 2 months. Depo-Provera, we've already talked about it. Then we have misoprostol, very common for termination of pregnancy. And we have conjugated estrogen here for menopause. You know, we are causing menopause in many patients when we do hysterectomy and we remove the ovaries. So some of them come back for hormone replacement. So that is these drugs. These are just examples of special drugs in obs and gyn, and then you need to pay attention to mechanism of action of each of the drugs, indications, contraindications, and route of administration. Like I think the last group, I asked them, how is anti-D given? Anti-D is given on the deltoid muscle. Yeah, it's given IM. So you need to know these basics. I like that. So that's about the drug station. This is one of the questions that came for another group. Which one of the incisions do we normally use for C-section? Can you fail this question really? Because you've been there in theater, so you know the incision that we've been using. And the answers are just there. I'm not even hiding the answers, you just pick. Is it 1, is it 2, is it 3, is it 4? What is a classical C-section? Some of you don't still know. We have a tutorial again on that YouTube on what types of C-section. A classical C-section is you cutting in the upper segment of the uterus. It has nothing to do with the incisions on the abdomen. It has something to do with the incision on the uterus. So we usually do a classical C-section when there's a problem with the lower segment. So we can't cut in the lower segment. So we go in the upper segment. So maybe there's a big fibroid in the lower segment, or there are adhesions in the lower segment, or there's cervical cancer in the lower segment, or maybe you have a transverse lie and you know that it's going to be difficult to extract this baby. So you cut a long incision in the upper segment. So that's about a classical C-section, but that tutorial has already been talked about. The number 3 question we've already talked about. What layers are you cutting through the abdomen before you get to the uterus? That is really basic. Absolute indication means that there is no other way. There's only a Caesar as a possibility. Some of you, you ask that what list an absolute indication for C-section, you say big baby. But we've seen big babies being delivered vaginally. So that's not an absolute indication. So that's about that. Then we already discussed maternal benefits, fetal benefits, maternal problems with C-section, maternal advantages with C-sections. Just look at that tutorial on C-section, which is on that YouTube thing where I'm posting all the tutorials. Then these are surgical instruments. We can't go through this one, but just look at them and see that all the instruments we have here, we have them there. I see that people struggled with number 7, which is a Babcock. We use it for, yeah, I've already talked about this in that tutorial. Use a Babcock to hold on to tubes. It's very gentle on tubes, the number 7. So you can use it to hold the ureter so that it's not cut. You put it in off the way, hold the fallopian tubes. Then we have number 3. It's a self-retaining retractor. But of course, I get surprised when people can't identify a cord scissors and an episiotomy scissors. That is like the saddest thing. I see episiotomy scissors and that cord scissors. So the thing is going to cut in about 4 minutes. So when it cuts, we just log in again for the last 15 minutes, then we are done. Especially for those people who are coming to the department for the first time, I think it will be helpful. I know we have new students that have come to the department. The tutorial I'm going to give after this is really for the people coming in the department for the first time, but I think it might be helpful for people who are about to write the exams as well. So that's about instruments. We can see the last one, number 10, is a Doyen retractor. If you've seen a C-section, we always use a Doyen retractor, so you can't miss that as well. Then this we've talked about already, the vacuum is always there. Because again, if you are in gyne, it's the only procedure we are doing on the gyne ward. So we are not putting this tutorial or this instrument there to make you pass. We are just sending a message that this is important. You must know it. You have no choice. So people are still struggling. What is A? Does anyone know what A is? I asked some people this and they didn't know. What is A? Hello? Can people hear me?
Yes.
Yes, I'm asking, what is A? No one knows. What about the ones here? The ones below, the ones connected to the cannula, the yellow, the green, the blue, and these things here. What are they? The colored parts. They are the same as the ones on top. What are the colored parts? What are they called? You people, time is running out. What is that
I
part?
just know it as a whole, as a cannula. I've never looked at the separate
The
components.
blue part, yes, the yellow part. That's an adapter. Again, if I don't know if it wasn't mentioned in that tutorial, I'll check it out, but that's an adapter. The only cannula without an adapter is size 12. So if you see a cannula without that part there, it means it's size 12, because it means that it can go into the valve without need for a cannula. It fits without need for a cannula. The other cannulas are small, so they need an adapter for them to fit in the valve. So that's about that. So this is just fluid. I already talked about this. And your specimen bottles. What fluid are you going to use for postpartum hemorrhage? People don't know that the ideal fluid for postpartum hemorrhage is actually Ringer's lactate. But normal saline can do too. So if you say normal saline or Ringer's lactate, that's fine. Yeah, but ideally Ringer's lactate. Then we already talked about the investigations, the common investigations which you should know. I think that was the last slide. We only have 30. What is this? We've been going for 39 minutes, isn't it? But it says we have only got 1 minute here left. So you just log back in if you are